Good morning everyone. This time I'm going to teach you about the dermatology chapters which are focused in USMLE. So without further delay, let's deal into the topic. We are going to discuss about tinea infections, seborrheic dermatitis, onychomycosis and candidiasis. I can give you timestamps so that you can access whichever topic you want to. So first let's start with the tinea capitis. What is tinea capitis and why is it caused by? Tinea capitis is a fungal infection which is caused by dermatophytes, microsporum as well as trichophyton species. So what is the treatment for tinea capitis? Tinea capitis is the one which will be occurring on the scalp. So generally for the infection caused by dermatophytes such as tinea corporis, tinea cruris, about which we will see in the next slide, topical ointment will do. But those where the topical penetration is not adequate, say for example in the scalp or else in the nail, oral treatment is necessary. This is the first point you should remember. Among that, what is the oral treatment? Oral griseofulvin is the treatment of choice. Then they might ask you in exams like if a person is suffering from tinea capitis and all those who come in contact with them, should they also be treated? The answer is no. Tinea capitis is not a communicable disease, or it doesn't contaminate through air. So you need not have to treat others who come in contact with them. In that case, how to then the next question is, in that case, if they want to if they don't want to contaminate from him, what are the precautions that the others should take? The others should take, preferably if the patient is suffering from tinea capitis, they should avoid sharing hats and personal items from him. Then the third question will be, okay, that if is medicated shampoo necessary for the unaffected? No need. Medicated shampoo is also no need. This is how the questions will be in USMLE. So I told you that there are many other dermatophyte infections, isn't it? What are they? When it affects the body, it is the ringworm or the tinea corporis. When it affects the foot, it is athlete's foot. When it affects the groin, it is tinea cruris. When it affects the skin, it is tinea capitis. Scalp, it is the tinea capitis. When it affects the nail, it is tinea unguum. The second condition that is commonly asked is seborrheic dermatitis. Here we are concentrated about seborrheic dermatitis of the scalp. So what is seborrheic dermatitis and to whom does it occur? Normally in certain people what happens is there is increased sebum production from the sebaceous gland. Where is the sebaceous gland? The sebaceous glands are present in our scalp, whereby it will be producing the sebum, which is an oily secretion which is necessary for the lubrication of the hair. But if there is excess of sebum production, then it favors the growth of an yeast called as Malassezia furfur. What happens? Because to react to that yeast, the body produces inflammation. That over inflammation to the yeast Malassezia furfur is seborrheic dermatitis, which is colloquially called as dandruff. So how do you treat this patient? Here we have to treat them with medicated shampoos such as selenium sulfide. So what you need to know it, the two most common dermatological conditions which any doctor would have seen is, one is seborrheic dermatitis, the other one is pityriasis versicolor. I will talk about it in detail. Pityriasis versicolor is also caused by Malassezia furfur. Seborrheic dermatitis is also caused by Malassezia furfur, but the over-inflammation to Malassezia furfur is the reason. Okay, so the treatment for both is going to be obviously the same. That is, the topical selenium is the treatment. So this is what I told you, oily substance from the sebaceous glands, and there is excess oil production resulting in redness, scaling and greasy patches. What is the relation between HIV and seborrheic dermatitis? Here you should know that seborrheic dermatitis can also occur, since it is due to colonization by the yeast, it can occur in immunocompromised patients. So they might give you, like men having sex with men, they are complaining of seborrheic dermatitis which is rampant of late. In that case, you need to suspect that they might have an immunocompromised, so therefore you have to check them for HIV. What about tinea corporis? Tinea corporis is colloquially called as a ringworm. Okay, so because it is in the form of a ring. So what do they want? How will they give you a hint that it is tinea corporis? Mostly the tinea corporis can be uh, contracted by contact with the pets or when sharing a communal surfaces like yoga mat. In those cases the tinea corporis can one can get a tinea corporis. Second one is they are mostly they generally they are ring shaped lesions with a clear center and scaly borders. Then third one is what is the treatment? The treatment for the dermatophytes is azoles. What are the azoles? Miconazole, clotrimazole, and ketoconazole. So generally topical miconazole or clotrimazole are first started, and ketoconazole can also be started, but ketoconazole has a broader range, so that is not taken as the first line in MLA exams. What about the cutaneous candidiasis? Cutaneous candidiasis is nothing but candidal infection which is occurring on the skin. So how will the pigment be? They will give you a middle-aged female who has a BMI of 55. So you should imagine that they are slightly plump, who has type 2 diabetes, and they have a red moist 18 to 10 centimeter ellipse kind of lesion under the right breast. Now the question asked what is the biggest risk factor. So now if you see the question that an ellipse under the right breast, so the candidiasis can be either due to rubbing of one skin over the other, or it can be due to since they have a type 2 diabetes, or it can be due to diabetes. So the question wants to check whether you know whether obesity is the highest risk factor or diabetes mellitus is the highest risk factor. Even though obesity causes moist skin folds, hyperglycemia, which is occurring as secondary to diabetes, is the one which will promote a fungal growth. So therefore hyper diabetes or hyperglycemia or insulin resistance is the biggest risk factor. That's what you should know. Now how will you treat the patients? See, as I already told you, for candidiasis the azoles are the main treatment. Whether you are going to give oral or topical, how do you decide? Since the major risk factor is a hyperglycemia, the treatment involves oral fluconazole. Topical alone will not be sufficient. Therefore, you need to treat them with oral fluconazole. So, generally for candidiasis, any candidiasis, fluconazole is the treatment. Oral fluconazole is the treatment. What about vaginal candidiasis? We know for sure that vaginal candidiasis generally presents with a cheesy white discharge. And so, what is the treatment option? So, there are two treatment options. Either you can give oral or you can give topical. It is not mandatory, unlike our diabetes, that oral is definitely the treatment. It is not like that. For vaginal candidiasis, either oral or topical can be given. Oral treatment is with fluconazole single dose, but topical treatment is with either nystatin or miconazole or clotrimazole. Which one to select, whether oral or topical? That will depend upon the patient. Sometimes the lesion will be on inaccessible areas, and due to compliance issues, the patient might not ask for a topical one. They might go for oral, and in oral, the other thing is there's a single dose fluconazole will be of great help. So compliance wise also that is very good. So in vaginal candidiasis, it depends upon the doctor to decide whether to give oral or topical. What about tinea pedis? Tinea pedis is again a dermatophyte which is occurring on the leg. As simple as that. But the question will not be as simple. Listen to me carefully. A middle-aged man who has fever, red itchy scaly area between his first and second toes. So you need to know that red itchy scaly area between the first and second toes mostly points towards tinea pedis, isn't it? But he has fever. That is the key here. Okay, let me continue the question. He also has redness scaling extends up to the dorsum of the foot and onto the ankle. Now the question asks what is the most likely causal organism for his fever. So even though the red itchy scaly area is due to tinea pedis is not going to cause fever. So when the redness or scaling extends up to the dorsum of the foot and onto the ankle, that means there is a secondary superinfection, which is mostly the staphylococcal cellulitis, which is secondarily superinfected the fungal infection. Therefore, the causal organism for this patient is Staphylococcus aureus, causing cellulitis as well as fever. So here, what should be the treatment? You need to address both the infections. The antibiotic should be given for Staphylococcus aureus and topical azoles should be given for the fungal infections. This is another question where they ask you about diabetic foot ulcer. They will ask you what is when a patient has a diabetic foot ulcer and there is a sterile probe which is probed to the base of the lesion is likely to show what organisms. So here if you see, this is the aerobic gram-positive cocci. This is the aerobic gram-negative bacilli. This is the anaerobic bacteria. This is the mixed flora, and these are the other organisms. So, even though a question like that is asked, the diabetic foot ulcers are characterized by, as you see here, polymicrobial infections. That's what should be the answer. What about a puncture wound? Okay, so imagine there is a puncture wound in a patient. But what do they say? The wound has been present for almost 3 weeks. The question is such that the young boy who's had a wound, but it has been present for almost 3 weeks, now presents with fever, and what is a likely organism? Now you should know that when a wound has been present for more than 3 weeks, it suggests a deep-seated infection. So likely it is involving the bone and it is due to osteomyelitis. So in that case, what is the most common organism in osteomyelitis? That is the Pseudomonas. So for diabetic foot ulcer, it will be polymicrobial, but for osteomyelitis, it will be Pseudomonas infections. There will be another question where they will be testing your knowledge about auto-infection. Here you should know that there is a patient who has a fungal rash on the ankle where he has been successfully treated with a topical clotrimazole. After that, they tell you that they have a similar kind of lesion which is on the groin. What is the cause for that reason and how does that happen? So you should know that a similar kind of lesion, that means it is almost belongs to the same category. That is, it must be almost a fungal lesion. Fungal lesions are generally excoriating, isn't it? So there will be a scratching behavior. So the fungus which is already been present, which has been treated, and even though it has subsided, the patient has scratched and it is resulting in an auto-infection to the groin. That's why this has happened. That is the reason for the second lesion which is appearing at the groin, which almost looks similar to the first one, even though the first one has been treated successfully with the treatment. So the reason is auto-infection. What do you know about chronic mucocutaneous candidiasis? So here, how will the question test this knowledge? Here they will give you that a child, maybe around a teenager, has a candidal infection since childhood. So along with the candidal infection, he or she has a 2-year history of type 1 diabetes and 1-year history of autoimmune thyroiditis. Now the question asks mechanism for the patient's condition. So here you should know that when they are giving you some autoimmune diseases like type 1 diabetes mellitus and autoimmune thyroiditis, you should know that they are clearly hinting towards some deficiency or aggravation of immunity. Fine. Here they are having type 2 diabetes mellitus and thyroiditis, but she is having candidal infections, skin infections since childhood. That is because there is a deficiency of cell-mediated immunity which is causing the patient to have a candidiasis from a childhood. The deficiency of T cell mediated immunity, along that is what there is a disturbance in the cell mediated immunity, which is resulting in thyroiditis as well as diabetes mellitus. So the mechanism for the patient's condition is deficiency of cell mediated immunity. And what is the diagnosis? Diagnosis: chronic mucocutaneous candidiasis. So whenever they give you about 2 or 3 autoimmune infections, then you need to very clearly associate your mind towards that, because that's what they want you to think. What about onychomycosis? Onychomycosis is a condition where there will be thickened nail bed following a fungal infection. It will be very simple. Old-aged farmer they will tell you that they has a thickened yellow nail bed of a left big toe. What is the diagnosis and what is the treatment? Diagnosis is onychomycosis, and the treatment is the thick areas like the scalp or the nails. Oral treatment is the first line, and here oral terbinafine is the first line treatment.